inviting me to give a talk on this training day. Teams is usually quite weird for me because I can not see anyone when my slides are on. So do stop me or signal for me to hear, because the problem is like I can't see anyone. All right. So as Darshan mentioned, I'm a neurodevelopmental pediatrician. I've been at the QE2, which is part of the Eastern North Hertfordshire NHS Trust. This is my 20th year as a consultant pediatrician there, and I've had training in various places in England and Scotland. And my interests include epilepsy, which I do a lot of, tic disorders, ADHD and ASD, and other chronic neurobehavioral conditions. So, as part of the training I've had for tic disorders, I did used to work in the Tourette clinic at Great Ormond Street during part of my during a training in neurology at US, and also I have an MSc in clinical neuropsychiatry from the University of Birmingham, and my dissertation then was on tic disorders. So I've had an interest in tic disorders since then. So part of what we hope to get from the training today is we to understand the varying presentations of tic disorders in children and young people, because we're very much aware that in the course of our career, I know many of us at different stages would have come across children with tics. Sometimes we may not have identified that they were tics, because children can present in varying ways in different parts of the hospital. Um, but this is to help us be aware of the presentation, and also to learn to improve communication with children and families of children with tic disorders through the process of assessment, diagnosis, and management. I was just talking with Darshan about the journey that lots of children with tics have to go through. Can you hear me? Can you hear me?
We can hear you.
Okay.
Yes, we can hear you.
Okay. Just the journey that a lot of the families have to go through to get a referral, because things are still quite haphazard in the UK and there's no unified pathway for referrals or assessment. So hope to improve the recognition and management of comorbidities, and also hopefully in our little way improve awareness of tic disorders within the wider community, including schools. So when we see children, how to communicate to the community they're coming from. And I put this because part of what Darshan wanted me to cover is to make sure that the training covered the communication aspect on progress and the health promotion aspect, which we have different parts in the talk today. So typically we will get referrals of different from GPs or other professionals, and they're quite variable. So one of such referrals was of a 6-year-old who had recent eye blinking episodes, head jerking backwards, mouth twitching. Episodes had been over 3 months, and parents were concerned that's in the GP, and they were referred to the hospital. The episodes were said to occur more at home than at school, and the birth and developmental history for Jay were quite unremarkable. There was no history of significant medical or drug history, but parents were very anxious about this movement, and they were very worried, concerned that there was something going on his brain. So they went to the GP, and the GP then referred. At this time, I'm sure if you were the one seeing the child, you'd be thinking about different things. And I wonder whether anyone could say what they would be thinking about. So I really can't see anybody, but if you could shout it out, I don't mind.
Focal seizures.
Okay, yeah. You could think about seizures, eye blinking episodes. There's some twitching, so yes, seizures could be a differential. Yeah. Anything else? So seizures is usually one of the things people want to exclude when they get such a history. Okay. This was a 12-year-old girl with long-standing anxiety. She also had a lot of OCD symptoms, and she recently developed sudden episodes of neck twitching, shoulder shrugging, throat clearing. She was making squeaky noises, blurting out some inappropriate words. The episodes increased in frequency and were present at home and school. Now, her schoolwork and relationship with peers were noted to have deteriorated. There were few attendances at A&E recently because of these behaviors. And what are the differentials? What would you be thinking about? So she's had this long-standing anxiety and OCD. Any ideas?
Tourette, Tourette
I mean,
syndrome.
one of the differences could be functional, although I mean that is exclusion, but still, in this age group and with background of anxiety, maybe.
Yeah, you'd still consider functional. Yes, I agree with you. Yeah, and somebody said Tourette, it'd still be a differential. Yeah. And I'm sure you've seen that there was a period where a lot of young girls were presenting to emergency departments with increasing tics. I don't know whether that has fizzled down, but certainly there was a period where we were getting quite a number of them coming in. And here was a 16-year-old girl with no previous concerns, normal birth and developmental history, normal difficulty, some difficulties with friendships when she moved to secondary school, anxiety and panic attacks in secondary school and school refusals. She then developed motor and vocal tics post-pandemic, was worse when she was outdoors in school than home. And sometimes the movements will last about 5 to 10 minutes. She'd sometimes appear vacant and confused after the episode. So what do you think here? What would you be thinking? It doesn't have to be a right or wrong answer, but what would you be thinking about? So sometimes it can be quite difficult even for the most skilled of professionals sometimes to just see them and know what it is because it's something you've got to work through and unpick many times. So but it's worth having an idea of how to proceed and how to explore these difficulties when you see the children because sometimes it can be quite um, exaggerated movements and quite impairing movements for the child and the family when you see them. Okay. So this man, Gilles de la Tourette, who Tourette syndrome is named after, um, was the one that coined the where Tourette syndrome was named after. But prior to this, actually, almost 50 years before that, there was a psychiatrist. There was somebody who had described a woman with symptoms where initially was thought to be mainly motor tics, and afterwards, a few years after, developed coprolalia and other features, which eventually, on retrospectively looking back, people identified that it was the same condition, Tourette, that was later described by Gilles de la Tourette. He actually collected case histories of about 9 patients who presented with a varying pattern of symptoms. And when they looked at the pattern and the trajectory, they found out that they were presenting with similar concerns, and the condition was subsequently named Tourette syndrome. Now, Tourette syndrome is part of the tic disorder, and so But people sometimes think of it as a very distinct condition. It is actually the part of the spectrum of tics. It's just the pattern where you have vocal and motor tics as opposed to just one tic. So what do we mean by a tic? So when we talk about tics, it's a very sudden, rapid, recurrent movement or vocalization. And some classifications have put tic disorders as part of a movement disorder because you can get just motor movements, which can be non-rhythmic, but you can also get the vocal part. So it tends to sometimes mimic part of a normal behavior that you would normally get. So something that the child could be doing normally, but it then becomes recurrent, and you see the pattern evolving. Now, it could be a tick could be just simple, in which case it only involves a few muscle groups, or um, in terms of the vocal tick, just very simple sound, in which case it could be just a cough, or a clearing of the throat. It just a simple sound or a squeak, or it could be much more a complex vocal utterances. So when it involves one muscle group, you call it a simple tick, and when it involves more muscle groups, you call it a complex tick. Now, a tic disorder, which Tourette falls under that, is a spectrum of conditions that can vary from just mild tics, could just vary from just mild eye blinking, or moving your eye to one side, or your nose scrunching. Could just be one of that, or it could be more complex where you have multiple movements, and you could have both motor and vocal tics. So a tic disorder is just a spectrum of what you can get along that movement. So we've talked about the simple motor tics involving one muscle group, and then the complex motor tics. You then have a combination. So it's not just one muscle group, you're getting different things happening. So you could have facial grimacing, head twisting, shoulder shrugging, all happening together. And that forms a more complex movement. So the child appears to be doing so many things at the time. And sometimes you can have children hopping, um, jumping, or hitting themselves, in which case they're using more muscle groups. And this could be a complex tic as well. Vocal tics, again, like we said, could be simple or complex. Um, and you can also have, with the vocal tics, the complex vocal tics, you can have the language, the phrases, the syllables, because you're using many and more than one muscle group to produce those sounds, and therefore it becomes a complex tic. Children with Tourette's could also have other things. They could have echolalia, repeating other people's words, or what we call palilalia, when they repeat your own words. So if I say something and then I repeat my own words, say the last part of what I've said, that's palilalia. But if I repeat other people's words, that's echolalia. And then disinhibited speech. Um, the speech could be disinhibited. They could blurt out phrases repeatedly, um, usually considered to be swearing. So, what people consider as in Tourette syndrome, saying, "Oh, the child is swearing," is just more of a complex kind of tic, where they've just blotted out things and they're not intentional. They're quite different from intentional swearing. So tics could be primary, in which case there's nothing that's wrong with the child that's led to that. It's just happened on its own, and you refer to those as primary tics. But tics could also occur as a result of, say, infections like encephalitis and strep A infections, and that was the post-strep A infections was the origin of the pandas theory, which led a lot of parents to seek treatment for pandas, because they thought treating the strep would result in resolving of the ticks, but we know that that's not really the case. Medications, head traumas, toxins, and substance use could all be implicated in causing secondary tics. So when you're taking a history, it's important to explore other causes. Now, over the years, we know of the DSM-5 criteria. So the DSM has changed over time. And in the DSM-4, we used to have a different from nomenclature being used to describe the same tic. So under the DSM-4, you had phrases like transient tic disorders or chronic tic disorders, but DSM-5, it's changed. So when you have tics lasting less than a year, and this happens a lot in children. So if you go to schools or go into the community, you have children who are doing random things like blinking or doing several tics, but they don't last more than a year. You call those provisional tics. If they last longer than a year, and if it's mainly motor tics, you call it persistent motor tic disorder. If it's vocal, you call it persistent vocal tic disorder. Now, Tourette syndrome, like I said, is the same spectrum of tic disorders. It doesn't mean that it's a more severe tic disorder. It's just describing the condition where you've got multiple motor and vocal tics together, lasting longer than 1 year. And you cannot attribute it to the effect of a substance or medical conditions. And that's what Tourette is. So sometimes clinicians are hesitant to give the diagnosis of Tourette because sometimes they feel, oh, it's more severe, but that's not the case. If you've had the child having multiple motor tics and vocal tics for longer than a year, that qualifies for a diagnosis of Tourette syndrome. So it then rests on us as clinicians to make sure that we educate parents properly so that they are aware that this does not mean the condition is more severe. It's just a description of what the child's presentation is. So going to epidemiology, prevalence for Tourette syndrome is said to occur in 0.5 to 1% of population, but we know that transient or provisional tic disorders, which we described as being present less than a year, occurs in a larger number of school-age children, up to 15%, and that's the percentage for the others. Male to female ratio, it's always uh, found that the boys present more, have a higher prevalence of 3.6 to 1. But there's also variations in that because it's felt that if you're in the hospital and you're seeing people presenting, obviously you'll be picking up on more of the referred cases. So it always depends on where your sample has come from. And the sample may change depending on where you are. There's an increased risk in families, so in first degree relatives with a history of tic disorders or Tourette, then you have a 10 to 100-fold risk. And this is quite interesting because in the clinics, it's sometimes quite interesting. You're exploring the history of tics from the family, and they're saying to you, oh, there's nobody with tics in the family, but you're actually sitting opposite a parent who is having eye blinking episodes or motor tics in front of you. So sometimes they don't recognize it because they don't feel it's severe enough. Um, I had a clinic recently, which was quite interesting, with a child who came to see me with parents were worried. He's developed some motor tics, quite complex motor tics, and they were getting quite worried, but the child was not impacted by it. But when I was taking the history from the father, he remembered that he used to do something similar when he was younger. And he also remembered he used to repeat words. He had palilalia and he had echolalia. And he could remember that quite distinctly, which then helped us to understand um, the family history during that exploring of history. Again, it's quite prevalent in monozygotic twins. It's higher, and for Tourette syndrome, it's said to be about 53%. Just for chronic tics, it's again higher in monozygotic twins as well. So who develops tics? So we've already explored that it's highly heritable. So if you've got a family history of tics, then there's a likelihood that that's where it's coming from. But we don't have a single gene being responsible. So what we have, there's still a lot of studies going on genetics wise, but they've found multiple genes that are implicated rather than single gene. And sometimes what's happened that in that family, there might be people who may have OCD in the family. They may not have had tic disorders, but there may be history of OCD in the family. And then you have the child from that offspring having, the offspring having tic disorders. And they've picked up similar genes in those people with OCD and tic disorders and Tourette's. So it's good to explore when you're taking the history. It's not just exploring any family history of tics, but ask about other associated conditions like OCD as well. Sometimes you might find tics in some neurological disorders, and if you think that there's a neurological condition, by all means, get that child seen by a neurologist to have a proper assessment. So what happens? What do we know about the brain in tic disorders? There's still a lot going on in terms of understanding the brain, but what it's been put down to is the networks in the brain. It's felt that there is immature brain networks. So between the cortical and subcortical levels, there is poor modulation of the network. So if we think about the fact that uh, cortical structures are fine-tuning the networks between the cortex and the deeper structures. And therefore, if you do not have that smoothing of movement, you then get a lot of release of movements, which shouldn't happen if things were working well. So if that process is not working well, then you would have these movements which come up and physically manifest as tics, and they've been thought to be abnormalities in the GABA pathways. And there's also been felt to be dysfunctional corticostriatal circuits, which are responsible for smoothing the function, the pathways. And like I said, the basal ganglia is involved in the control of voluntary movements and abnormalities, and any disorders in that process would result in all these movements that you see and the variety of movements you get in TS. They've gone further to look at functional MRI studies and DTI studies, which have shown abnormalities in the neural tracts between the cortex and basal ganglia. So just think about the problem in those circuits. So if you look at this, you get the diagram on the top, you've got the prefrontal cortex. There's a lot of network projection between the cortex and the deeper structures. And that's why when you think about Tourette syndrome and think about all the other manifestations that you get, you can understand why the emotional component is there. The amygdala, you can see projections of networks between the cortex and the amygdala, the cortex and the thalamus and the hippocampus. So there's all these circuits going on. And if things are not smoothing, you will get additional behaviors. So just think about this, just like we've talked about. And anatomically, it's been found that there's reduced volume of the putamen and global pallidus, and the blood flow has been set to be affected. So there's decreased blood flow, and there's increased dopamine binding due to receptors. So one of the things that's been proposed is that there's a lot of dopaminergic activity. So there's hyperstimulation of the thalamic nuclei, and you get a lot of those movements. So some of the medications that have been used to treat Tourette syndrome are actually targeting the dopaminergic activity. And other neurotransmitters have been implicated, but the evidence is limited. So coming to practical things, when parents come to you, they want to, they're asking several questions. So you're seeing their child with tics, but they're very keen on finding out what's the cause of my child's tics. Can this be cured? Is it likely to occur again? Can it be stopped? And what are the treatment possibilities? So these are questions that parents usually come up. And so it's good for us to have some information to give to parents when they ask us these questions. What we do know about the clinical cause of tics is that they usually have their onset between age 5 to 6 years. We're now seeing children with the onset a little bit younger. Usually it used to be about 5 to 6, but we've certainly seen some who've started a bit younger. And we know they peak around 10 to 12, mid-childhood. Usually about this time is when they're usually more florid, and then they start dying down. And usually by adolescence, a bit 2/3 of them would have gone down or be resolving. the ticks may change within the same child. So parents may say, oh, he's developed a new one. I've seen something that wasn't there before. They get more worried. So it's good for you to know the progression. Typically, you get more ticks on the upper part of the body. The motor tics tend to precede the vocal tics. They're usually brief, sudden, and the vocal tics may, and sometimes vocal tics may arise before motor tics in some cases. Sorry, that was an error. So you tend to get the upper body being affected with eye blinking and facial movements. So as clinicians, getting the history about the onset, how they started, because the likelihood that you sometimes children have tics, they come to see you in clinic and you're not seeing any tics at all while the child is with you. So it's very good to get the history. You want to know the course of the symptoms, the severity, family history, and then we're going and screening for comorbidities, which we're going to talk about. Then you examine the child, you do a full neurological examination, a full clinical examination on the child. But as you're doing that, you're also observing the child. One of the things that is good to be aware of is that sometimes when you're talking to the child directly, you might not observe any tics. But if the child is doing an activity that they're more relaxed in the clinic, so give them an activity to do in the clinic that they're quite relaxed in and take your attention off them and be talking to parents when you sometimes might pick up tics when they're not directly being watched or spoken to. And so it's good to be aware that even when you're taking your history, you're looking at the child at the same time. You video recordings are quite good. A lot of parents do this voluntarily now. They will bring recordings of the child having tics, which is usually very helpful because in the clinic, the child most likely will not be doing the tics. So actually seeing a recording of the child doing the tics is quite helpful. And it's something that we do ask parents to record and bring to the clinic, just like we do with seizures. Most of the children that we see usually have normal neurological examination. We don't usually need to do a brain scan for children, and you only would do investigations if you're concerned that this is not very typical presentation. Now, we talked about comorbidity screening for comorbidities, and that's because the tics, it's very rare to have just pure tics on its own. A lot of times you have children with tics having all these other things, which are comorbid things that you find in tic disorders. The commonest ones are things like ADHD, obsessive compulsive disorder, anxiety. So it's very important that when you're doing your questioning and screening or history taking, that you're exploring concerns around this, because these are the things that might be more impairing for the child rather than the tics itself. So comorbidities are very common in children with tic disorders, and mood disorders, anger, rage, and aggression is actually quite common in them. They can't explain why they have those rages, but it's quite common. And tics can, like I said at the beginning, tics can present to other parts of the hospital. We should have it at the back of our mind that that child with coughing bouts and the cough being quite stereotyped, or having repeated throat clearing, which has been treated for allergies repeatedly or treated with different medications, might be a tic and might not just be an allergic cough. So things to consider when you're doing your clinical assessment: check that this is a chronic onset, the child, check whether the child was unwell before the episode, and if it was acute, explore all the other concerns like fever, rash, or sore throat, any neurologic symptoms. Obviously, if the child is acutely unwell, then needs an acute assessment to check the child and check for neurological conditions. So screening, asking questions about comorbidities is quite important, and you should be familiar with short screening questions to ask about any of these conditions when you're assessing the child. We've talked about clinical examination. Sometimes we give questionnaires. So there are questionnaires called the Yale Global Tick Severity Scale, which is a detailed questionnaire which explores the motor and vocal tics and explores the duration, explores the past and present symptoms, and parents sometimes who forget the different tics the child has had. Usually with the symptom checklist, they can take and say, oh yes, the child had this before, because some of them forget. So they'll be able to talk about the age of onset and when the tics were worse then. And then there's another questionnaire. So this usually is completed by the child or you administer it directly to the child. And this is looking for something called premonitory urge for tics. So this questionnaire is useful because a lot of children with tics, if they're able to express themselves, are able to describe how they feel before the tic and how having the tics make them feel. And one of the key things that helps to support your formulation of a tic disorder is the presence of premonitory urge in tics. But we also know that some children find it difficult to express this, but if you have that information, it also helps you in your assessment. So typically, a child with a premonitory urge is such that if you think about where you were sitting down and you're having a sensation of feeling like blinking your eyes or scratching your skin, your hand, if you're feeling having an urge under your skin to scratch it. But assume you're in a meeting or a training session and you're trying very hard not to scratch, but you're having that sensation and you're trying to avoid it because you're doing a presentation or you're in front of you're in front of a seminar where you don't want to do that, but that urge is building up more and it's causing you a lot of discomfort. And you get to the point where, unfortunately, if you don't do that each, you're not going to get a release. And that's exactly the sensation that children with tics have. So children with motor tics might be able to describe the uncomfortable feeling that they have over the area that they do the tic before they do it. And so this question is actually exploring those urges, feeling pressure, feeling tense, and feeling that something is not just right and how they feel after this has happened. So the higher the score, the higher the likelihood of premonitory urges. So it can be localized or generalized. They have the urge, then the tic, then they feel the relief. So we also know that there's a variation in the way children experience tics. Some children are trying to suppress the tics at school, in class, because they don't want to be the center of attention, and they come back home and they're doing lots of tics. That doesn't mean that the tics are more severe. It just means the child has been voluntarily trying to suppress the tics whilst at school. So the absence of tics does not necessarily mean that, oh, the child is cured, or the increase of tics doesn't mean the child is having more severe tics. And so we should be cautious when we're using those measures as defining severity. So part of my MSc project was speaking to children aged 6 to 10 about premonitory urges. And the reason I did this, because it was thought that children between age 6, children less than 10 could not express premonitory urges. And premonitory urges are quite important because you need that when you're putting children forward for behavioral management of tic disorders, because they need to be able to define or talk about their premonitory urges as a form of treat before you can do the treatment. So children younger than 10 were not being exposed to that management because it was felt they couldn't report that. But what I did find in my interview with some of the children is that they had their own words in which they used to define these premonitory urges. And that brings us to the communication part that we were talking about, as part of our domain, Progress Plus domain, is being able to communicate with children of different ages to get them to express exactly how they feel. So they had things, the way they've described this feeling, and from the way they described it, you could notice that that's what they were describing. And there was a child, a 9-year-old, who said she's tapping her ankle. She's trying to stop the tick. One said she says to the thoughts, go away, I don't want you in my life. And so there were different things. They talked about those urges distracting them. And this was very important because some children were felt to be very distractible and could probably have ADHD, but actually some children with tics, it was the tics itself that was distracting them. So when do tics occur? Anytime. It could be occur when the child is relaxed or doing activities. They're less frequent when the child is doing things that's more engaging, but sometimes it could occur more in periods of stress. Sometimes overexcitement could increase it, anxiety. Um, they may be forceful and appear unusual. They may be exaggerated. They may be obvious to people. Sometimes the people are not really watching and looking out for it. They might miss it. Some tics may be very forceful and result in self-injury. So we've had children who have injured themselves from their tics where they've actually had to get treatment. So when we're exploring tics, what we're looking for in terms of severity or impairment is actually we look at different things. How impairing is there? How impairing is those movements of the child's academic achievement, self-esteem, interpersonal, and then families also get quite bogged down by this. Sometimes we get families who really feel down because they feel they can't go out with the child because of the tics, and so they isolate themselves because of the stigma. ADHD, very common. Tourette syndrome and ADHD can impact social functioning and academic achievement, so we should screen for this. When you have ADHD and tic disorders, it can be quite um, significant that that child may be heavily impaired. And you do sometimes find that those children have other things like anxiety and mood disorders. So when you're managing ADHD and tic disorders, you have to think about what kind of medication that you're using in those kind of situations. Again, these are other comorbidities. OCD is another very common comorbidity with children with tic disorders. Make sure you always ask about OCD symptoms. So it's not just enough to get the history for the tic disorders, but get the history for the OCD as well. With the OCD, the child has intrusive thoughts. They do repetitive behaviors to make sure things are just right. Because if they don't do it, they get very anxious and very distressed that they just have to do it to relieve them of that distress. They some can get compulsions as well. So make sure that you get that history because sometimes people categorize those behaviors as part of the tic disorders, whereas they're actually separate OCD symptoms. It's important to recognize and refer for management as well. Autism spectrum disorder, um, it's been found in varying populations, prevalence between 2.6 to 11 in some reports of children with Tourette syndrome. Anxiety, very common, and mood disorders, very common in children with tic disorders. Again, very important to screen for this. So just not thinking about the tics itself, but thinking about the comorbidities, because what's impairing the child most times is the comorbidities. Other things that you do find are the learning, the sleep, and the rage attacks. And you can find that in a number of children. So should all children with tics be treated? No, the answer is no. So a lot of children with tics are quite happy and they're not bothered by the tics. So it's our role as clinicians to be able to. A lot of parents, when they come in, they don't understand what the child has. They've gone in Googling and they're worried. So your role is to be able to see the child, examine the child, reassure the parents about what it is, and then, signpost them to information. So most children do not actually need any treatment because they're not bothered by the tics. You only say tics are impairing when it is bothering the child. They do not need any active intervention. But the children who have impairment and significant disruptions need to be referred. So when do you worry? What are the features of impairment that causes you to worry and refer? If you've got a child who's got significant motor tics that's causing them a lot of discomfort, pain, injuries like they're bruising and falling and hitting themselves, disruption in their learning, isolation and bullying, mental health issues, then you need to refer. When the tics are persistent to distress the child, um, and the confidence is low, yes, you need to refer the child. So how do we manage tics? The first line is psychoeducation. So communicating with the families and the child. Don't forget the child, because you can convey that message to the child about what is happening to the child, and use simple analogies to explain to the child what is happening and reassure them as well. You can also empower the child, and we encourage children to be able to speak about their tics to their friends in school, and some schools have been very good with allowing children with tics to talk about their tics in assembly, or talk about their Tourette in their assembly, and this has actually enabled the rest of the school to understand them. And you can do things like environmental modifications. We advise schools sometimes, if the child is doing a lot of tics, to allow the child to have a break, a movement break, and just go for a break where they can go out, be relaxed, and do their tics, and then come back to the class. And then we have behavioral therapy and then medication. So when you're communicating with a child, listen to parents' concerns, find out what they've read or heard about the condition, and then discuss how tics wax and wane. New tics can come in, but the condition is benign, and then discuss treatment and signpost them to resources. How can the teachers and the school support the child with tics? So the parents and teachers should meet to discuss the nature of the child's tics. So it's important the parents discuss this with the school, let the teachers know. We've had cases where children are being told off for having tics in class. The teachers are, telling them to stop doing that. And when you tell a child to stop doing tics, they do it more. So anytime you talk about tics and saying that in front of the child to stop it, it triggers them to do the tics even more. So partnership between the parents and school is very important. The teachers should create opportunity to talk about tics. We've talked about that, and then creating a calm environment for the child, and look at whether there's any stressful event occurring in school that is contributing to the child's tics. How can teachers support the child? So check in regularly with the child. Have a homeschool communication book to communicate with families, giving them updates, and then promote relaxation activities. If you find out that the child is doing a lot of tics, sometimes you can engage your child in more movements, asking the child to help in classroom chores, because tics lessen when the child is more engaged in activities. So thinking about differential diagnosis, I've put some here which we need to think about. So not everything that comes as a tic is a tic. Think about, could this be any other thing? Could it be myoclonus? Could it be a tremor, dystonia? Just think about it and be very sure that what you're seeing falls into the pattern of tics. Could it be seizures? We've seen the first child where one of the differentials was that could this be a seizure? OCD behavior sometimes can feel like tics, and then stereotypies, which are quite different from tic disorders, and you tend to find them in children who children may have stereotypies without being neurodivergent, but they could have it with children with learning difficulties and ASD. And stereotypies are purposeless movement. The child just likes doing this activity. They seem to be in a world of their own when they're doing it. But you can see that it just keeps the child is not distressed by it. Um, so they actually enjoy the feeling of doing it. And motor stereotypies tend to happen earlier. So if a parent comes and tells you movement started before the child was 3, then that's less likely to flow with the pattern in takes. Remember, we said the onset is usually from about 5 for takes. With stereotypies, you can easily distract the child from the take, from doing the activity, which is different from take disorders. comorbidities are quite high in both conditions. With spermatostereotypies, the movements are usually the same, they're repeated in the same pattern, and the child likes the movements. I was just putting this because we talked about functional tics, and this was something that came up a lot after the pandemic, where we were seeing a lot of children presenting with what appeared to be tic-like movements. And we saw this a lot in young girls who were coming with these prolonged movements that looked like tics, but a lot of them were functional tics. And we saw a wave of them during the pandemic and after. And again, a lot of children were said to have been watching TikTok videos, and this led to a rise, and some of them were called TikTok tics. So again, it was unmasking a lot of children with anxiety. And as some of these children we've picked up, we're still picking up, some of them have had ASD, which was never diagnosed. So what we're picking up is that anxiety, these functional tics were anxiety driven. I've got videos, but unfortunately I haven't had the consent to share some of these videos, but I've had some collection of some very florid presentations. Um, Undiagnosed neurodevelopmental disorders like ASD have been picked up in a lot of the children presenting with functional tics. There was high rate of misdiagnosis in treatment, so some of them were being treated like they had tic disorders. So in terms of investigations, we have said that it's mainly history and clinical examination or video assessment. You only need investigations when things are abnormal. So majority do not need treatment. We've talked about that. We've talked about the need to work with families to deal with the stigma. Um, sometimes parents are on different pages, there's conflicts, there's caregiver strain, there's strain within siblings and relatives as well. There's also the school challenges. So parents can be under a lot of strain when dealing with this. So in terms of behavioral interventions, these are quite effective. Unfortunately, it's not been quite easy to access. So in the past, it was mostly face to face, but then there are online behavioral treatments, and there are plans to see how those can be expanded so they become part of regular treatments. And basically, what's happening in the behavioral treatment is you're teaching the child to recognize the premonitory urges, and you're using strategies to work on those urges so that eventually you help the child to suppress the tic. So it's quite a different topic talking about the behavioral management, but just remember that there are two types. There's the habit reversal therapy, where you work on one type of tic at a time, choose a tic that bothers the child most. The therapist helps the child become aware of the tic by recognizing the urges. Then you teach the child a competing feeling that they do when they feel that urge. So, for example, if they've got an urge on the side of the neck where they tic, then the therapist teaches the child to do a competing movement, and that might be holding the neck in a particular way until that urge goes down, and eventually that urge, the tics gradually go down over time. It does take a while. Whereas exposure response prevention, which is another form of management, is the child recognizes the urge, but rather than teaching them a competing feeling, you teach the child to hold on to that urge for a long time. You increase the interval between which the child can hold on to that without doing the tic, and eventually that helps the child as well to have less tics. Medication is used when behavioral treatments have not worked, or things are very impairing. Um, and one thing we should remember is that the goal is never to get rid of the tics, because children will always have tics, and having tics does not equal to impairment. So the goal is not complete elimination of the tic, but to alleviate the discomfort that is preventing the child from accessing what the child needs to access. think about treatment for the other comorbidities, and drug treatment is another class of things. But for us, one of the commonest things we use is things like clonidine or guanfacine if the child's got ADHD and tic disorders. And there are other medications that are used, but some of those are used by psychiatrists. And there are other treatments that are being used now for treatment of refractory tics, like deep brain stimulation. These are conducted in tertiary centers. Wearable devices are now coming out. They've been found to have a place in management of tics, and you've got devices like that where the child or the person wears a tic, the device, and that's supposed to pick up on the stimulation to help reduce the tics. In terms of prognosis, tics resolve in 50% of children by age 18. They get better as the child grows older. So these are things that you need to be able to reassure parents, but you have to manage the comorbidities as well. So again, there's some books that have been written, and they're all the resources for managing ADHD, tic disorders. So summary is that most children with tic do not have impairment in their functioning, so they can be happy tickers and going along. You need to work with the child, you need to work with the family, you need to work with school to reassure them, and also creating a stress-free environment for the child makes things better, and partnership between parents and school is key. So I think that's the end of my talk. I'm just going to try and get back to Sue.
Brilliant. Thank you so much, Dr. Takon, for the fantastic session. That was really, really useful. And I've learned so much about tic disorders, which I'm sure everybody else has as well. Did